This is a part 3 of the musculoskeletal system guideline, and in this particular part we are going to learn about the vertebral column surgeries. Very important topic because there are many codes and one must understand them so that your coding will be always correct. So this is the diagrammatic presentation of the vertebral column. We must know that the cervical are 7 vertebrae, C1 is atlas and C2 is axis, thoracics are 12, lumbar are 5, and then we have a sacrum and coccyx. So sacrum are 5 but they are fused, coccyx are 5 but 3 they are fused, and in all 33 vertebrae. This is important because whenever we are coding for the vertebral column, we must know the number of the vertebrae. That will help us to count the number of the segment and the interspace properly. So let us understand the various procedure we carry out on the vertebral column. One is arthrodesis, second is a bone grafting, and the third is a spinal instrumentation. So in the spine procedure, one must understand what are segments means, what is spaces means, what is bone graft means, instrumentation, arthrodesis, nerves, and more. Now, if you take the view of the vertebral column, this is called as a vertebral bone, and in between the two vertebral bone, this particular pink structure, what you see, is called as a disc. Now, many a time the problem with the vertebral column happens because there is a problem with the disc. So this is a normal disc. Sometimes the disc bulges out either anteriorly or either posteriorly. So the bulging, the herniation, the degenerative disc is basically the changes in the disc as per the age and the thinning of the disc. So these are the problem we face in the vertebral disc. So these are the two important terminology you must know. One is a vertebral segment. Vertebral segment is nothing but a complete vertebral bone. So the green part which I have shown here is nothing but a segment, and vertebral interspace is nothing but a intervertebral disc, and I have shown it in the pink part. So the interspace and segment, these are the terminology they have referred all through this particular chapter. So some more procedure here. So the first is the corpectomy, which identifies the removal of the vertebral body during the spinal surgery. So we remove the complete vertebra. That is called as a corpectomy, and facetectomy is nothing but the excision of the facet joint between the two vertebral bodies. So you can see this facet joint present between the two vertebral bodies, and when we remove that, it is called as a facetectomy. The next important medical term is the discectomy. In the discectomy is a surgical procedure that removes the part of a damaged spinal disc, and if you can see here, we have removed the disc, and that is called as a discectomy. And laminectomy, it is a surgical procedure that removes a part or all of the lamina. So suppose this is a vertebral bone, and you will see this part is called as a lamina, and when we remove that, it is called as a laminectomy. All these surgeries are done to relieve the pressure on the spinal cord and the nerve. Now some more terminology. The first is a approach. So when we are doing the surgery on the vertebral column, we approach the vertebral column either from the front, which is called as the anterior approach, or from the back, which is called as a posterior approach. Then discectomy is removal of the disc. Arthrodesis, that is, you fuse both the vertebral segment together, which is called as arthrodesis. Number of the disc or the segment, that is the interspace and segment that we have seen. Bone graft and instrumentation. So we will see each one by one. So whenever you are working on the vertebral column coding, first you have to identify what type of procedure has been done. Then identify what approach the surgeon has taken. Has he taken the posterior or anterior? Because that will decide your code. Then identify which vertebra. Is it a cervical, thoracic, or the lumbar vertebra? Then we have to count the number of the segment and the interspace. And we will use the modifier 51 while coding the multiple procedure on the same side. So if you have done the laminectomy, that is we have removed the lamina and then the patient underwent arthrodesis, then that time we will have to use the modifier 51. So these are the various approaches that we take whenever we are working on the vertebral column: the anterior approach, the posterior approach, and the lateral approach. And depending upon that, the codes are divided. So there is a code range for the anterior, posterior, and the lateral. So I'm going to show you how the code language is so that it will be easier for you to understand. So the anterior approach is a surgical technique that involves making an incision in front of the body to access the specific area, and the code range we have seen. So if you see the code 22548, you can see it is very clearly written arthrodesis anterior transoral or the extraoral technique, and then the vertebra is also written. And here also you will see the anterior interbody technique. So everything, whenever they talk about the anterior approach, the code language is very clear about mentioning that approach. And of course the vertebra are also mentioned, thoracic and lumbar. So pay attention to all those details so that you will never go wrong in your coding. So the posterior approach is a surgical technique that involves making an incision from the back. Okay, and again the code range is written, and let us see the language: posterior technique, posterior or posterior lateral technique. So everywhere the technique and then the vertebra is clearly mentioned. Pay attention to that. And the third is the lateral technique, and you will see the lateral extra cavity technique, and the vertebra is also mentioned in every code. Now, in a medical billing, a primary surgeon refers to the main surgeon performing a procedure, while CPT code 62 is a modifier used to indicate the two surgeons, each considered a primary, which work together to perform the distinct parts of the surgical procedure during the same operative session, essentially signifying the co-surgery. So whenever there is a very big surgery that is happening, there are two surgeons who plays the main role, and both are called as a primary surgeon, because there is one assistant surgeon also who does a very smaller work or a lesser work, but primary surgeon both will work, both will have the same role, and whenever they do the surgery they will put a modifier 62 on their on the procedure code. Now let us understand bone graft. It is a substitute that is needed to create the environment for the solid bridge. It allows the new bone formation to fuse the section of the spine together. Bone graft is either the morcellized or structural. An important consideration is we do not use the modifier 62 along with the bone graft code, and this is what they have given in your book too. Now the bone graft, they are divided into allograft or autograft. Allograft means donor's bone and autograft means patient's own bone. And morcellized means when we use the bone powder form, and structural means we use the bone block from the patient's bone or the donor's bone. So that's the only difference. Now let us understand what is a spinal instrumentation. Spinal instrumentation refers to is used during the spine surgery. The goal is to stabilize the spine in order to prevent a motion while fusion occurs between two or more vertebrae. And in that we have a segmental and non-segmental. Segmental means we have a small segment, and it is attached to at various level, while the non-segmental has only two hooks, one at the proximal end and one at the distal end. So, and remember that we never use the modifier 62 on the instrumentation. In your book, they have mentioned the segmental instrumentation and non-segmental instrumentation separately. Pay attention to the language here. It is very clearly given the segmental instrumentation. The parenthetical notes below every codes are very important, because they give you the clue for with which code you can use this instrumentation code. So pay attention everywhere. The parenthetical notes are written, and they will help you to choose the right answer. So the recap is the two surgeons work together as a primary surgeon performing the distinct part. Then each surgeon should report his distinct work by appending the modifier 62. Then the bone graft procedures are reported separately. In addition to the arthrodesis, we never put a modifier 62 on the bone graft. And as per as the instrumentation, it is also reported separately in addition with the arthrodesis, and we never put a modifier 62 along with the definitive or an add-on spinal instrumentation procedure code. And when arthrodesis is performed along with another procedure, more definitive procedure like fracture care, laminectomy, osteectomy or vertebral corpectomy, then bill arthrodesis service with a modifier 51 except on add-on code. So let us take this example from your book so that you will understand how to put a modifier 62. A 42-year-old male with a history of post-traumatic degenerative disc disease at L3, L4 and L4, L5 underwent a surgical repair. A surgeon A performed an anterior exposure of the spine with a mobilization of the great vessel. Surgeon B performed the anterior discectomy and a fusion at L3, L4 and L4, L5 using anterior interbody technique. So how will you report this procedure? So in this case, the surgeon A will write 22558 that and append a modifier 62, 22585 and append a modifier 62, and surgeon B also will write 22558 append a modifier 62, 22585 append a modifier 62, and surgeon B also did the fusion, okay, because and for that he will write 20931, but we will never put a modifier because this is the code for the graft, and we will never put a modifier of 62 on the bone graft. So this is how they will write the this is how the coding will be written. Now let us take this example. Here they have given the posterior arthrodesis L4S1 utilizing morcellized autogenous iliac bone graft harvested through the separate facial incision and pedicle screw fixation. So let us do our drill. Identify the type of the procedure arthrodesis. Identify the approach posterior. Identify the site, it is L4 to S1. Count the number of the segment and interspace. So let us do that. So it is L4, L5 and S1. So how many segment? 1, 2, 3, because segment is nothing but a vertebral bone. And how many interspace? Interspace is nothing but a vertebral disc. So we have two interspaces. Remember, the number of the segment minus 1 is the interspace. So you have the two interspaces, 3 segment. Now we'll see the code 22612. It is this code, lumbar vertebrae. This is the indented code. So I am going to read the code arthrodesis posterior technique. In our case, it is a posterior technique. Single interspace, cervical below C2, and this is the lumbar. So I will take this code, but it talks about only the single interspace. We have two. So each additional interspace we are going to take 22614. So that covers our two interspaces. Now there is a 22842 code that talks about the posterior segmental instrumentation and example pedicle fixation, and here they have given 3 to 6 vertebral segment. So here they are counting the segment, here they are counting the interspace. So pay attention to those words because they are very important. So this covers our instrumentation. Now there is one more code. What is that code? That is a 20937. It is a morcellized code, a morcellized graft. And did it happen? Yes, morcellized autogenous iliac bone graft. So we will use that. And you can pay attention, these are the add-on code. So we will always write the arthrodesis code first, followed by the instrumentation and then the bone graft code. So this is how you code for the arthrodesis patient. So now let us take this example. The treatment of the burst fracture of L2 by corpectomy followed by arthrodesis of L1, L3 utilizing anterior instrumentation of L1, L3 and structural allograft. Now let us see what is the first code. The first code is 63090. This code talks about the vertebral corpectomy, partial or complete transperitoneal or retroperitoneal approach, and it talks about irrespective of the vertebra, that is whether it is a thoracic, lumbar or sacral, for all that we will use only one code, but it talks about only single segment. In our case, what is a segment? Segment is a vertebral bone, and they have removed L2. Removed why? Because they have used the word corpectomy, and we know corpectomy. And here I have given the table also, that will also help you to check quickly that the lumbar vertebra single segment, that is a 63090, and each additional segment we use the add-on code, but in our case only one vertebra has been removed. Now what is the second code? 22558. This code is this code 22558 lumbar, but this is the indented code. So I'll be reading the primary code. This is their primary code: arthrodesis, anterior interbody technique including the minimal discectomy to prepare interspace, and they have given the cervical. As is lumbar, but it is individual interspace. In our case, how many interspaces? Interspace is the the area in between the two vertebral bone. Now here there are how many bone? L1, L2, L3. That means three segment and two interspaces. So I will use the code 22558, but it covers only single interspace. Now 22585 is each additional interspace. I will require that code also. And 22845, it talks about the instrumentation. But for the instrumentation, they use the word segment. How many segments? We have L1, L2, L3, three segment, 2 to 3 segment. So it covers that. And 20931, allograft structural, for which we have structural allograft. So I'll be using this code. Now why I'm using the 51 modifier? Because if you remember that whenever the arthrodesis is done along with the definitive procedure, that is the corpectomy here, we will use the modifier 51. So that answers all your doubts, and this is how we code for this particular case. Let us take one more example. After adequate anesthesia was obtained, the patient was turned prone in kneeling position on the spinal table. A lower midline lumbar incision was made and the soft tissue divided down to the spinous process. The soft tissue was stripped away from the lamina down to the facets, and discectomies and laminectomies were then carried out at L3, L4, L4, L5 and L5S1. Interbody fusions were set up for the lower three level using the Danek allograft and augmented with a structural autogenous bone graft from the iliac crest. The posterior instrumentation of 5.5 mm diameter titanium rod was then cut to the appropriate length and bent to confirm the normal lordotic curve. It was then slid immediately onto the bone screw at each level. Compression was carried out as each of the two belts were tightened so that the interbody fusion would be snug and as tight as possible. Select the appropriate CPT code. So first thing is what is the approach? Now here they have not given the clear-cut approach, but there is one important sentence that will tell you what is the approach, and that is the patient was turned prone and kneeling down. That means the approach is a posterior approach because the patient was lying on his face. That is called as a prone approach, and that means the approach is from the back. So the posterior approach, and then we have to code for the how many interspace, L3 to L4 1, L4 to L5 1, and L5 to L6 S1 1. Three interspace, three interspace are there. Then the and see the number of the segment will be 4, and then we need to check for the allograft, then we need to check for the instrumentation, and after putting it all together we need to find out our answer. So I'm giving you 1 minute, tell me the answer. So this is the answer. So we began first with a posterior approach, and I told you the prone position is lying face down approach. So the surgery started from the back, and that zero down our answer for the posterior approach. We did 3 interfaces. So the primary code is for the first interface, and add-on code is for the each additional interface. This is the code for the instrumentation, and we used 2 graft. One was a allograft and autograft, which was a structural autograft. So we will have to code for that. So this is the final answer. Now these are the code for the percutaneous vertebroplasty and vertebral augmentation. The codes are given here. Just pay attention to the code. This is the code for the percutaneous vertebroplasty, which is performed one vertebral body, unilateral or bilateral. It includes the image guidance, and it is cervicothoracic, and this is a lumbosacral, and this is a common add-on code for both 22510 and 22511 for each additional vertebra. And pay attention to all the parenthetical note in this particular section all through. Sally suffered a burst fracture to her lumbar spine during the skiing accident. Dr. Phyllis performed a partial corpectomy to L2 by transperitoneal approach, followed by the anterior arthrodesis of L1, L3. She also positioned anterior instrumentation and placed a structural allograft to L1, L3. How would Dr. Phyllis report this procedure? So find out, this is the anterior approach. There is a corpectomy that has been done, and instrumentation has been done, allograft has been put. So if you see the code 63090, it is a vertebral corpectomy, but it is a transperitoneal approach, while 63085, it is a transthoracic approach. So option B is not the correct option. And then we will see the 22612 is not the correct code, because it is not the code for lumbar vertebrae arthrodesis anterior approach. So we cannot even use that code, and so is the D answer is also wrong, because first of all, whenever the definitive procedure happen, that we have to code first, followed by the arthrodesis, and here the definitive procedure that has happened is a corpectomy. So A is the correct option. And this is my last slide, and there is a one more part is remaining that we will finish shortly.